So good evening once again and welcome to this weekend tutorial. We're going to be looking at pediatric emergencies. Hopefully we'll not have any issues today. Okay, so these are our learning outcomes. At the end, everyone should be able to recognize common pediatric emergencies encountered in anesthesia and critical care settings. Okay, be able to describe the unique anatomical, physiological, and pharmacological considerations in managing these emergencies. And everyone should be able to outline the diagnostic approach and immediate management steps for life-threatening conditions in this age group. All right, so this is, remember the last time when we talked about the principles of pediatric anesthesia, we did mention the need for us to have a dedicated OR for them. So this is an example of the kid OR. All right, make it as much as possible to be children friendly. Okay. So introduction, pediatric emergencies, acute life-threatening conditions that occur in neonates, infants, children, or adolescents. And these conditions require immediate recognition, prompt intervention, and skilled management to prevent preventable morbidity and mortality. One thing about these pediatric emergencies is that they often progress rapidly due to the unique physiology and limited physiological reserves in these children. Okay, so the first thing we're going to look at in managing pediatric emergencies is what we know as the pediatric assessment triangle. All right, this is a rapid, structured, and visual assessment tool that are used quickly to evaluate the severity of illnesses in a child within the first 30 to 60 seconds of patient contact. All right, and you do not need any equipment, or there's no need to also touch the patient. All right, so this consists of three key components forming what we know as a visual triangle. The first one is look at the child's appearance. All right, this has to do with the tone. You look at the interactiveness. All right, the consolability, the look of the child and the speech. Then you look at the breathing pattern. How is the child breathing? And you can look at the circulation. So we'll look more into this. So let's look at the appearance. The first 30 seconds to 60 seconds of coming in contact with a child who is sick, you want to look at the appearance, and this talks about the neurological and global perfusion status of the child. So use the mnemonic tics, all right? Tone, is the child limp, or is he or she moving spontaneously, or are there vigorous movement? Interactiveness, does the child respond appropriately to people or to the environment? Consolability, all right, can the child be easily comforted by the parents or caregivers? Look at the gaze, the look of the child. Are the eyes tracking your movement? Are they focused, or they are just staring, or maybe what we know as the absent gaze? Okay, speech or cry. Is the child crying strong and normal for age, or they are weak or hoarse or absent? All right, all of this can give you a picture of the neurological status of the child. The second one is a breathing pattern. All right, so look at the respiratory status and effort. So the first thing is looking at the airway sounds. All right, is there any abnormal airway sounds like struggle, grunting, or is there wheezing? Look at the positioning of the child. All right, is the child in tripod position or is the sniffing position? Retractions, you look at the suprasternal, intercostal, and subcostal region and to look out for retractions. Nasal flaring, head bobbing, this is the movement of an infant's head in relation to respiration. So from this, you can make an easy, quick assessment. All right, so if there's increased work of breathing, this patient most likely will be in respiratory distress. Or the breathing is decreased, or there's absent work of breathing, especially where it's associated with alter appearance or alter mental status. So this will give you an impression of an impending respiratory failure. All right, looking at the circulation, this will give you an overview of the cardiovascular function and the rate of perfusion. All right, early signs of powerful perfusion anemia can be seen with pallor, conjunctival pallor. All right, looking at the skin, are they patchy? All right, this is usually due to poor peripheral perfusion. Cyanosis, it can either be central or peripheral cyanosis, which is a late sign of hypoxia. Is the skin flushed? All right, this could normally be seen in sepsis where you have distributive shock. So from the circulation, you may be able to discover any type of shock, all right? Maybe hypoxia or poor perfusion from sepsis. So just the pediatric assessment triangle comes handy, all right, looking at the appearance, looking at the breathing, and looking at the circulation. Okay, so this table puts them together. So if there's abnormal appearance and the work of breathing is abnormal, meanwhile circulation to the skin may be normal or abnormal, this patient is likely in respiratory failure. But if the patient is normal in appearance, but the work of breathing is abnormal, but the circulation of the skin is normal, so most likely this patient is in respiratory distress. Abnormal appearance with normal work of breathing, but the circulation to the skin is abnormal, this patient is most likely in shock. So when you have abnormal appearance, abnormal work of breathing, abnormal circulation, this is impending cardiopulmonary arrest. Okay, and when you have an abnormal appearance, normal work of breathing, normal circulation to the skin, you could have a metabolic problem to deal with. So the second quick assessment when you have a case of pediatric emergency, you can also use the ABCD approach, all right? So airway assessment, you want to look for airway patency, ruling out any sign of obstruction, all right? And you want to also determine if the patient is able to maintain adequate ventilation and oxygenation with correct positioning. All right, breathing, looking at the chest and abdomen for respiratory excursion. And you want to evaluate the depth and the rate of breathing. You want to look out for signs of hypoxia, dyspnea, and determine the saturation of oxygen with a pulse oximeter. All right, so circulation, you want to check for the pulse rate and the volume to determine adequate cardiovascular function. Determine the capillary refill time and the blood pressure. Know that roughly you can estimate the normal systolic blood pressure in a child with a formula 70 plus twice the age. And this is important because you want to rule out any form of, cardiovascular impairment. Instability, quickly use the AVPU, all right? Is the patient awake? Does it respond only to verbal or pain, or is the patient not responsive? Know that the pediatric Glasgow Coma scale can also be used, okay? Abnormal disability tests such as altered or reduced level of consciousness will require immediate resuscitation, even including sometimes endotracheal intubation and ventilation. So exposure, this is important, and I discuss this a lot, especially in the ICU environment, where we often neglect to adequately expose our patient. So for a child who is seriously ill or injured, you want to ensure adequate exposure, which may reveal burns, bruising, fractures, or any other evidence of other injuries. And this is where your secondary survey comes in, where you obtain focused history from parents or guardian or caregiver. Don't forget the Apple history, which has to do with allergies, medications, any past medical history, last time of meal, and the event leading to the present situation. All right, this will follow by a detailed general and systemic examination. Okay, so the pediatric Glasgow Coma Skull is a little different, all right? Especially it has to do with a verbal response, okay, and motor response. And these are things that every one of us should be very familiar with. So let's now go down to the common pediatric emergencies. And the first one we're looking at are common airway emergencies in the pediatric age group. Okay, so the first one we're going to look at is upper airway obstruction, croup. Okay, and I think this is the one that I looked at last time. Are you sure? Because I don't have questions here now. Okay, let's go on without the questions. Okay, no problem. Let's go. We have a lot to talk about. Okay. So the first upper airway obstruction we're looking at is croup, the laryngotracheobronchitis. All right, this is a viral infection most commonly caused by the parainfluenza virus, which primarily affects the upper airways, causing swelling and narrowing of the airway. Okay, the features of croup is you can use the mnemonic back. So the child comes with a barking cough, all right, a audible stridor, usually inspiratory, and you have respiratory distress, which may be mild to severe. And don't forget that this usually affects kids, typically from 6 months to 6 years. And these symptoms actually worse at night. So remember back, all right, to be able to remember the features of croup. Okay, so severity classification, mild back, when you have a barking cough, there's no stridor at rest, and no significant respiratory distress. For moderate stridor, now we have stridor at rest, mild to moderate retractions, subcostal, intercostal retraction, but the patient is still having normal mentation. When you have stridor at rest, significant distress, marked retractions, agitations, and you have either peripheral central cyanosis, or you have severe croup. But when the patient becomes lethargic, there's decreased air entry, patient is cyanosed with altered mental status, you have impending respiratory failure. So what are the indications for admission? Most cases of croup are managed on an outpatient basis. But when you have stridor at rest, okay, following the mnemonic stridor, or the patient is tired or toxic looking, there's respiratory distress as evidenced by marked chest retractions, flaring, grunting, or increased work of breathing. Patient is unable to take adequate oral intake, and patient is desaturating with SpO2 below 92%, all right? And ongoing need for interventions when you need to give the patient repeated doses of your interventions like nebulized adrenaline, and the patient fails to respond adequately to the initial therapy. All right. Other risk factors for admission include if the child is less than 6 months and there has been history of pre-existing airway anomalies, serious comorbidities, or the patient has poor social support. So these are indications to admit this patient, this child, for closer monitoring and management. So when you have a case of croup, throw a dice, okay? Dexamethasone at 0.1.5 to 0.6 milligram per kg IV if the patient is not tolerating orally. Inhaled adrenaline, all right? Cool, humidify air, comfort, and calm environment. And you want to evaluate the air, oxygen, and you want to continue to monitor. And if the patient's condition worsens, you want to escalate to invasive airway care with endotracheal intubation or tracheostomy. Okay, so that is croup. The second airway emergency is epiglottitis. Epiglottitis. Commonly, we need to be able to differentiate between croup and epiglottitis. All right? This is a rapidly progressive, life-threatening bacterial infection. Croup is more of a viral infection, while epiglottitis is a bacterial infection involving inflammation of epiglottis and adjacent supraglottic structures, often leading to acute upper airway obstruction, commonly caused by Haemophilus influenza type B bacterium, and some can be caused by strep or staphylococcus species. All right, remember that for croup is aged between 6 months and 6 years, or epiglottitis is common among age group of 2 to 7 years. And the features, remember the 4 Ds: drooling of saliva, dysphoria, dysphagia, and distress, associated with a sudden onset of high-grade fever and the patient assuming a tripod posture. All right, so this will give you an indication of likelihood of epiglottitis. Okay, so significantly, there's absence of a backing cough, unlike in the case of croup. And the lateral neck X-ray will show the swollen epiglottitis as a top sign. So we know the classical top sign of epiglottitis. So initial management, this is crucial. Do not panic. All right, when you panic, you worsen the patient's condition. So what do I mean by that? Do not attempt to visualize the truth, all right, with any tongue depressor, because this may trigger complete airway obstruction. Or you want to give the patient oxygen, high flow supplemental oxygen, and immediately you want to notify the ENT team for airway management. See, tranquilize minimally, try to keep the child calm, and let the patient assume the position of comfort. Usually, they assume the tripod positioning. Avoid unnecessary procedures like IV access, if need be, must be gently done. All right, observe the patient for immediate airway support, and usually, airway intervention must be done in a controlled environment, especially in the OR or any emergency department that is equipped for airway care. The C, continue to monitor this patient, pulse oximetry and cardiac monitoring, because they can, all right, decompensate so rapidly. So the care, the definitive airway care, the preferred setting is in the OR, all right, with the ENT and anesthesia team. Know that this is crucial. The kind of induction, you must use inhalation induction because you're trying to avoid any form of pain that may be caused by IV access. So inhalation induction, you want to maintain spontaneous ventilation. You don't want to lose the airway. So the most senior person, all right, must be they want to attempt intubation. All right, this is not the time to guess, all right, the technique of airway intubation, appropriate size cough tube. All right, make sure you avoid airway relaxants until you have secured the airway. And if intubation fails, that is why what we say most of the times, do not attempt intubation until you have the ENT not just present in theater, they must be scrubbed, ready for surgical airway in case of difficult or inability to intubate this patient. So antibiotics, immediately after airway is secured, you want to cover this patient with appropriate antibiotics, all right, that will cover the targeted bacterium, all right? So cephalosporins, the third and fourth generation cephalosporins, all right? And sometimes when methicillin-resistant Staphylococcus aureus is suspected, you want to add vancomycin, all right, which suggests that gram-positive organisms or clindamycin. Typically, you want to continue antibiotics to about 10 days, depending on the patient's clinical response. Adjuvant therapy like steroids, this will help to reduce airway edema, all right? Nebulized epinephrine may be less effective than in case of croup, but you can use it consciously. More importantly, if you want to give humidified oxygen to this patient. All right, so you see the epiglottitis. This is how the child will sit up, okay? You can see the patient has respiratory distress, high fever, all right, cyanotic leaves, muffled voice, that is dysphoria, drooling, all right, dysphagia, and distress, the 4 Ds I talked about. You can see the subcostal retractions, okay, and the tripod position to maximize airway mechanism, okay. So air rate, I got this from the net, okay, air rate, some of the features of epiglottitis, the airway is closed, okay, there's increased pulse tachycardia, patient is restless, you can see as if the patient is being strangulated, okay, there's retractions, there's increased anxiety, the patient is anxious, and I, inspiratory stridor with D. So you can either use my own, the 4 Ds, which is dysphoria, dysphagia, all right, distress, and drooling. The alternative is that epiglottitis, there's an air raid. Okay, so the question here, the issue here, do not attempt to examine the truth, like we mentioned before, because this can lead to acute airway obstruction, complete airway obstruction. Allow the patient to assume the position of comfort, okay? And this is very important for the patient to be able to breathe adequately. Okay, so this table just shows us the differences between laryngo what's it called? The croup, laryngotracheal bronchitis, and epiglottitis, okay? So this is just about like 10 differences between croup. I remember those days that is a common questions, all right, at part 1 level, all right? So everybody should be able to differentiate between croup and epiglottitis because the management differs. Okay, so the other airway emergencies common in children is foreign body aspiration. All right, this could result either in complete or partial airway obstruction. Occurs usually in children less than 3 years and is the commonest reason for bronchoscopy in the 1 to 3 year age group. Most of the objects lodge in the right main bronchus because of their anatomy. They are shorter, they are straighter, okay? And very important is the type of foreign body that's been aspirated. All right, peanuts, for instance, like granite and all that, these worse, they have a worse cause and outcome, all right, because they can cause intense inflammation, all right, within few hours. So the history of foreign body aspiration is based on 3 C's: coughing, choking, and cyanosis. So if you have a child present to you coughing, choking, and cyanotic, you must be able to have in your mind that this patient most likely have aspirated a foreign body. The 3 C's of choking, coughing, and cyanosis. All right. So aspiration of peanut and other organic substances can lead to what we know as a lipoid pneumonitis. It's a form of chemical pneumonitis that is caused by the presence of the lipid materials in the lungs. All right. It most commonly occurs after aspiration of oil-rich organic materials. And that's why, when my children growing up, I was very hard on them. Don't, some children play when they're taking nuts and all that, okay? So nuts, seeds, beans, for instance, vegetable oils, all right? These sometimes can, cause lipoid pneumonitis, all right? And they can present acutely. The painful thing is that sometimes it occurs weeks after the initial aspiration, and which may be silent or unrecognized. The parents or caregivers may not be aware, all right, that the child has aspirated these oil-rich organic materials, all right, but they nonetheless present with a very terrible outcome. So how do you manage foreign body aspiration? You want to obtain a chest X-ray, which will show unilateral inflation of one side. Removal is usually via region bronchoscopy under GA, all right, with an experienced anesthesiologist present. This is important. There are different ways. I hope I have it here. Okay, yes. So there are different ways of anesthetizing patients with foreign body, poster for foreign body aspiration. Number one, the preferred method is you want to allow spontaneous ventilation. Okay, so your induction will be inhalation with sevoflurane, which is preferable. But if the child already has an IV access, propofol may be used. Okay, the advantage of spontaneous ventilation is that this keeps the patient to maintain the airway tone and reduces the risk of foreign body dislodgement. But it's also not without limitations because you can have the risk of hyperventilation with carbon dioxide accumulation. All right, this patient may cough on you, and you may have laryngeal bronchospasm, which may make the cause of anesthesia turbulent. Then we can have controlled ventilation. Controlled ventilation is really preferred in esophageal foreign body, or if the patient has unstable airway. All right, you want to use SOSA, all right, for short procedures, all right, because SOSA is short acting, okay, and you want to maintain with short acting agents like sevoflurane or propofol. Remember that during intermittent positive pressure ventilation, the aspirated foreign body may be pushed distally, all right, making removal more difficult or complicated. There's the third one, apneic ventilation, all right? And this is where the patient is not breathing, but all right, you provide oxygen by your high flow nasal cannula, or you may use your standard nasal prongs, delivering 100% oxygen. The high flow nasal cannula has other added advantages because it can humidify and heat the oxygen that is given to the patient. Okay, and the high flow nasal cannula prolongs safe apnea time, allowing for more controlled foreign body removal. Okay, know that it does not provide ventilation, and this may lead to carbon dioxide accumulation. And a lot of times, apnea ventilation should not be prolonged more than 10 minutes, 5 to 10 minutes at the most. Okay, and this is why it's important we have experienced hands on board, both the is it the ENT surgeons or the cardiothoracic surgeon who is removing the foreign body, and the anesthetists must be the most experienced around. So adjuvant medications and techniques, glycopyrrolate helps to reduce secretions for clearer vision during bronchoscopy and foreign body removal. Topical local anesthetic agent like lidocaine can help block airway reflexes, reduce the risk of laryngospasm or bronchospasm, and you must be able to have your emergency airway equipment ready, all right, intubation, suctioning, and you should be able to have your tracheostomy kit, all right, readily available in case of complete airway obstruction. All right, so intraoperative monitoring, standard ASA monitoring should apply, at least 5 of them, all right? Consider capnography, especially if your patient is breathing spontaneously, in order to be able to intervene in case of rising end-tidal CO2. You must be able to monitor for desaturation, bronchospasm, or the movement of the foreign body, either in the trachea or in the esophagus. Post-operatively, you want to monitor for airway edema, evidence of obstruction like stridor or spasm, continue humidified oxygen, nebulized adrenaline or steroids. Give as much as an analgesia, be generous, all right? And if there's complicated extraction, the surgeons are finding it difficult to remove the foreign body, or in the event of airway compromise, you want to admit the patient in at least a high dependency unit, all right? This is not the kind of patient you want to discharge to the ward, because complications like airway obstructions may develop, all right, even hours, okay, after attempt at removing the foreign body. Okay, so the other airway emergency is the bronchiolitis, all right? Usually occurs in infants less than 2 years and causes acute viral lower respiratory tract infection. Most common cause is the RSV virus, others are parainfluenza, adenovirus, and even the human metapneumovirus. The clinical features of bronchiolitis includes gradual onset with running nose and mild fever. Patient may be tachypneic. There may be evidence of wheezings or crackles on chest, auscultation, and most of these patients may have feeding difficulties. In severe cases, patients may be apneic, lethargic, cyanotic, and this patient may actually progress to respiratory failure. So the management of bronchiolitis is supportive, all right, with oxygen therapy, proper hydration, and nasal suctioning. In severe cases, you may want to give CPAP, especially in ICU or high flow nasal cannula. But some of the medications, bronchodilators, all right, corticosteroids, antibiotics, are not usually routinely indicated. You intubate the patient only if there are episodes of apnea, or the patient becomes exhausted, or there is evidence of severe respiratory failure. Okay, airway of emergencies, status as asthmaticus can happen in children greater than 2 years. And status asthmaticus occurs, all right, as a severe life-threatening asthma exacerbation that is usually unresponsive to your standard therapy. All right, most of the patients have severe dyspnea, tachypnea, and tachycardic. All right, they're unable to complete full sentences, and they make use of accessory muscles or respiration. And when this chest is silent, it's an omnial sign, okay? And they can have pulses, paradosis, and hypoxemia, all right? When you're having carbon dioxide retention, that is a late sign, and this may lead to carbon dioxide narcosis with altered mental status. So it's important to be able to categorize the severity, okay, of status asthmaticus in this patient. And there are 3 different parameters, all right? And in severe cases, this patient is breathless at rest, speaking in words only, marked respiratory failure, and pulsus paradoxus, when respiration is actually with more than 10 to 15% reduction in blood pressure. All right. The peak expiratory flow rate usually less than 50% of predicted, and SpO2 is less than 92%. All right, even with oxygen therapy. So this is severe. All right. So signs of life-threatening asthma: silent chest. All right. Patient is cyanotic, bradycardic. Initially, they are tachycardic, but by the time they become bradycardic, it's a sign of life-threatening asthma with a peak expiratory flow rate of less than 33% or maybe unrecordable. Patient may become unconscious. All right, this requires urgent ICU admission and care. So you need to smash the asthma. So we talked about all smashed, okay? Stepwise management. Oxygen, high flow oxygen. You want to target SpO2 of greater than 94%. Okay, short-acting bronchodilators. All right, like your repeated, what's it called? Salbutamol. Magnesium sulfate if the patient has poor response to your salbutamol. Anticholinergic may be added, all right? Systemic steroids, okay? IV fluid, because of agitation, they lose fluid, they become dehydrated. Also ensure that you avoid fluid overload. You may need to escalate to aminophylline, all right, or ketamine. Ketamine usually be useful, especially in cases of status. All right, be ready to decide to intubate if the patient deteriorates further. Okay. So what are the indications for intubation in status asthmaticus when the patient is crashing? All right, C, carbon dioxide is rising with acidosis, pH is less than 7.2. Reduced level of consciousness, or the patient becomes agitated. Use of accessory muscle, all right, with fatigue or exhaustion. When the chest becomes silent or severe hypoxemia, despite maximum oxygen therapy, and when the patient becomes hypotensive or cardiac arrest. So we need to prevent the patient getting to this stage. But sometimes we get to see them when they're already crashing. And that is why you need to intubate and ventilate this patient appropriately. So airway ventilation for severe impending respiratory failure, usually you want to use ketamine for induction because of its bronchodilatory properties. All right, intubate, then use low tidal volume. You can allow permissive hypercapnia. You prolong the expiratory phase. All right, sometimes we do 1:3 IE ratio to avoid air trapping. Don't forget that they already have airway obstruction, so you want to prevent air stacking, and you prolong expiratory time to 1:3. Okay, so that is the common airway emergencies in pediatric group. The next one we're going to look at are the common pediatric emergencies, cardiovascular emergencies. But before I go on, do we have questions or clarifications about the first group of pediatric emergencies, airway emergencies? Do we have any questions or contributions, multiplication, addition, or subtraction? Colleagues, I hope you have been hearing me. Hello?
We can hear you, Prof. No comments.
Okay. No comments, nothing to talk about. Tinashe.
Hello. I just need a clarification. I think when we were discussing about croup, there was a bullet which you mentioned that we need to nebulize with adrenaline.
Yeah.
5 mils of adrenaline of 1 in 1,000. So does it mean I need to break those 5 vials, then I nebulize with all of them?
Yeah, it depends. You know, sometimes it depends on the dose of adrenaline that you have. All right, but appropriate dose in 100,000 is best. All right, sorry, 1 in 1,000, not 100,000. Okay, because you want to get vasoconstriction and reduce the edema that you know may lead to airway obstruction. Yeah.
Okay, thank you very much.
You're welcome. Any other clarifications on airway emergencies in children?
Hello, sir.
Yes.
Thank you, sir, for the presentation. I just want to, I want you to clarify intubating patients with acute epiglottitis.
Okay, what clarifications do you want?
Yes, sir. Well, it used to be said that the patient must be, while pre-oxygenating, patient should be seated. So it's
Yes.
after induction that you now flatten the patient. I don't know if that is still, that still holds.
Yes, because you know, like you said, the patient is always in tripod position because that is the best position for them to ensure adequate oxygenation. So the patient should be in seated position, you're right, where you put your mask. And remember that you are doing one breath induction. So the sitting is not too long. And this is where you want to give high, you know, concentration of sevoflurane. You don't want to do stepwise induction. So you give your sevoflurane at high concentration, and while the patient is seated position. A lot of times we allow the parent or the caregiver, because it also helps to reduce anxiety and agitation with this patient. Remember that anxiety, agitation can predispose the patient to airway obstruction. So you want either the parent or the caregiver, all right, holding the hand of the patient in seated position with a mask. Sevoflurane is the best in this kind of condition. But if you don't have, halothane can also be used. But don't forget that you may require higher and the prolonged time of induction with halothane compared to sevoflurane. All right, I hope that helps. And like I said, you know, the most senior person, this is not, you can't have an acute epiglottitis patient in almost airway obstruction as a resident. You must get your consultant and the ENT surgeon must not just be available in theater. A lot of times those days I used to tell them, you can't sit in theater or cross your hand. I want them scrubbed, ready for surgical airway should the need arise. Okay. Does that help?
Yes, sir. Thank you very much, sir. But sir, in a situation where we don't have maybe Allothane is not available and then Civil is not available, can we use Propofol and Soxa, sir?
Propofol, Propofol can be used, but this is an airway. The ideal thing is to do inhalation now. All right. I wonder what kind of settings you have that you don't have. It will be difficult for you to have an OR without inhalational, induction, especially. Even in most emergency rooms, you have anesthetic machine. But should that happen, like what?
It's isoflurane that we have available here, sir. I know Allothane. Well,
no, sevoflurane is the best, but you don't want to use isoflurane because isoflurane will cause airway irritation and will increase the risk of airway obstruction, especially laryngospasm. And once you have laryngospasm or bronchospasm, you won't be able to intubate that patient. Okay?
Okay, sir.
So,
yes, thank you.
But please don't use isoflurane. If you have isoflurane, it's better you use propofol, all right? And do a careful, what's it called? IV access and use your propofol. And try to avoid Soxa, all right? Try to avoid Soxa, and that is why it's important for you to be able to have adequate dose, okay? And intubate at one pass. Okay.
All right, sir. Thank you very much, sir.
Thank you. We have only 8 minutes more. Any other question?
Prof, I have a question, sir.
Yes, Dr. Monday as well.
Yes, sir. With respect to apneic oxygenation, are we going to paralyze before commencing?
No. Don't paralyze this patient. Don't paralyze this patient. Apneic oxygenation sometimes, when the patient is, maybe not ventilating well, all right? But most of the times, paralysis comes after you have secured the airway because of manipulation with your bronchoscopy and all that. But don't paralyze the patient until the airway is secured because you can lose the airway once you paralyze the patient, So it's important for you to make sure that you secure the airway, and paralyzing the patient must be with Soxa, all right? And non-depolarizing muscle relaxant may be used if you have sugar matters, all right, to reverse your rocuronium. But most of the time, the soxametonium is ideal. And when you're giving the soxametonium, that's when apneic oxygenation comes in, because that is where either the ENT surgeons or the cardiothoracic surgeons are busy with their rigid bronchoscope looking for the foreign body. So, but don't give muscle relaxant until you have secured the airway. And the reason why we're talking about apneic ventilation is because you don't want to give IPPV. You don't want to ventilate the patient because you risk dislodging the foreign body further in the airway, or if the foreign body is in the esophagus, all right? So that's why we want to do apneic oxygenation, prevent IPPV, but ensuring that the patient is adequately oxygenated. All right, does that help, Monday?
Yes, sir. Yes, thank you.
Okay. Do we have any other consultants who may want to give your experience? Let's give some experience. Those of us who have had to manage patients posted for bronchoscopy and all that, or even patient being managed for airway obstruction, either due to croup or epiglottitis. Any other person, consultant, give your input, please. Angelic. Okay, Chuko, you want to say something? I think Angelic is a pediatric anesthesia fellow, if I'm right. You want to say something?
Yes. It's okay. I hear many things. I really enjoyed the presentation.
Yes, tell us your experience. What do you think?
So, my experience, what do you think? As he said, mainly is a preparation to be prepared with all different, if mask, or airway, or different materials. In the case of management, in terms of airways, in terms of medications, especially emergency drugs, those atropine, adrenaline on resuscitation dose, and also to be prepared with the team. And also another things I observed is to be systematic, as we said, when we are managing those patients. Thank you.
Thank you, Dr. Angelic. Thank you. All right. Any other person wants to contribute? I think we can go on with our presentation. Pediatric emergency is usually very big, very broad. So we'll take our time so that we exhaust everything we need to exhaust. All right. Any other comments? We still have about 3 to 5 minutes. Dr. Mashaba, our registrar, are you around? Doctor, okay.
Yes, I am, Prof. Thank
Yes,
you very
good
much.
evening, ma'am. Yes.
Good evening. Thank you very much for the lecture. Very
Yes.
enlightening presentation. Thank you.
All right, you're welcome, ma'am. Thank you. Dr. Adesina, are you here? Any other consultant? Okay. So the important thing here is to be calm. Do not panic, like we said concerning management of epiglottitis. Do not panic, okay? Because if you panic, you're going to cause more harm than good. Like what Dr. Angelic said, be systematic preparation, adequate preparation with the team, all right, adequately briefed role assignment. And I always emphasize, please do this, ensure that the ENT team is brought on board as early as possible. And this patient, the ENT surgeons must be in theater scrubbed, ready for intervention should the need arise. Okay, so if there's no other questions, maybe we should call it an evening. And then next week we continue with the pediatric emergencies. All right, Betty Mangombe, where are you from? I want you to say something. That name, I don't think I've come across that before. Betty, are you there?
Yes. Yes, Prof, I'm here.
Please pronounce your name.
It's Betty Ntemangombe.
Ntemangombe. From Zimbabwe, I guess?
No, I'm from Malawi.
Oh, Malawi. All right.
Yeah.
So make a comment. What do you think? What's your experience?
Yeah, it was a nice presentation. I enjoyed it. Maybe a question would be, when is the right time to give the glycopyrrolate in a child with, for instance, croup?
Yeah, they look at the secretions, because you're using glycopyrrolate as a drying agent here. All right. So
yeah,
most of the times, even for foreign body removal, and all that. So the secretion, when you have secretion, I remember just this when we started anesthesia, atropine, glycopyrrolate are usually very easily available, and especially if you are going to use ketamine for induction because of its bronchodilatory property. A lot of people will give glycopyrrolate routinely, all right, as in addition to the ketamine, all right. So ketamine will increase secretion production, and this patient primary pathology also involves secretion. So glycopyrrolate is usually given if you are going to use ketamine for induction.
All right. Thank you, Prof.
You're welcome. All right. So let's call it an evening, everyone. And we're having lesser people join us every session, maybe because of the hiccups we have had in the past 2 weeks. But hopefully we should have overcome that. And let's let people know that we are on and we'll continue to give our best. Thank you very much, and do have a good evening, everyone.
Thank you, sir.